Hello friends, I am Dr. Harsh Mathur from Om Netralaya, Varanasi, India. This video contains an operative procedure meant for eye surgeons for education purposes. Viewer discretion is strongly recommended, not meant for children. So, she is a 62-year-old female and the main challenge was the narrow palpebral aperture, and it's a NS2 cataract. So the angulation of the instruments had to be adjusted, but if you are sitting temporally, then managing these narrow apertures and deep sockets is quite easy. So by now the side ports have been made, the anterior capsule has been stained, the main incision, a triplanar incision has been constructed, and another side port is made. So this 5.5 mm marker will help me guide my rhexis. So it's a 26 gauge bent cystitome, and by raising a flap and just continuing with it in a circular fashion, just guide this flap and we get a good 5.25 mm of rhexis. Now as it is a soft nucleus, so my plan is to do a supracapsular phaco, tilt and tumble. So a gentle wave of PSS is done. I am judging the density of the nucleus and it seems it should prolapse easily. So now a continuous wave is injected and this one pole prolapses out. Now the endothelium is protected with the OVD. The probe of cataracts 3 phaco machine is introduced. In this case, the phaco power is 40, flow rate is 38, and vacuum is 400. So now buzzing into the central core of the nucleus, the chopper or the dialer goes behind and we get a partial crack. So I'm trying to dial and get hold of the nucleus. So this one quadrant is free, so I'm going to emulsify it. Now this proximal part was still attached, so I'm dialing it and now I'm getting a good hold. I'm trying to separate the proximal heminucleus with the quadrant, and once it is free it gets easily emulsified. The other heminucleus has gone back in the bag, so I'll be holding and chopping it into two parts and then it gets easy to emulsify. So in no time the nucleus is managed, endothelium is protected nicely, the parameters are lowered now, and this epinuclear sheet needs to be flipped. So just trying to catch hold of one part and now it gets flipped easily and gets emulsified. And that's it. We are done with the nucleus in no time, and with the help of a 22 gauge Simcoe cannula, the cortical matter is removed. The subincisional cortex is removed by taking the Simcoe cannula through the side port. The chamber is deep and this subincisional cortex is accessible easily, and in no time we are done with the cortex. A wound assisted injection of the IOL is being done. It's a hydrophobic IOL. The leading haptic goes in the bag and the trailing haptic is then dialed in. The OVD is then nicely washed from behind the IOL and from the anterior chamber as thoroughly as possible. So the take home message is, in these small palpebral aperture eyes, a temporal approach is always helpful as it gives us a better access. So try it next time. I hope you like this video. Do like and subscribe the channel. And thanks for watching.